All right. Thank you. Good morning, everyone. Thank you for joining us. My name is Joan Batorf, and I'm delighted to welcome you to our webinar today. And I want to begin by acknowledging that the land on which we're gathering today, at least here in Kelowna at UBC Okanagan, is on the traditional unceded territory of the Silk Okanagan Nation and their people. I also acknowledge that some of you might be joining us from outside the region, both from near and far. And I also want to acknowledge the traditional owners, past and present, of those lands as well. So as I mentioned, my name is Joan Batorf. I'm a professor in the School of Nursing at the UBC Okanagan campus, and I'm also director of the Institute for Healthy Living and Chronic Disease Prevention. And on behalf of our planning committee for the 8th annual Okanagan Embrace Aging Month, I want to thank you again for joining us today. Embrace Aging is co-hosted by the Institute for Healthy Living and Chronic Disease Prevention here at UBC, but also by Interior Savings Credit Union and Interior Health. We launched Embrace Aging about 8 years ago with 4 presentations. And over the years, it's grown considerably. And this year we have over 30 presentations that all are focused on raising awareness about positive aging. And if you've looked at our program, you'll notice that we have a variety of topics for young and old, for really everyone. Our goal is to really inspire everyone for positive aging. So you'll notice at the bottom of your screen, or on your screen, there is a closed captioning box that prints out everything that we say. If you would like that box turned off, if you find it distracting, you can go to the bottom of your screen and you'll see a live transcript button that you can use to turn off the captioning. You can also move the captioning to another place on your monitor if that's more convenient. We will have some time for questions and comments, and so I encourage you to put any comments or questions you have in the chat box anytime during the presentation. And at the end of the presentation, we'll go back and look at those and we'll read them out to our speakers today and have a conversation about those issues that you've raised. So without further ado, I'd like to introduce my colleague, Michelle Smith, who is the Regional Practice Lead, Research and Knowledge Translation, Long-Term Care and Seniors Care at Interior Health. And Michelle is going to introduce our speakers this morning. Michelle.
Hello, thank you, Joan. It's good to be here with everybody. Today, I work a lot with these two lovely speakers, and I'm really happy they're here today to join us and share all their expertise. Today's session is Stroke Care and You, Innovation and Research in Interior Health, and our speakers are Dr. Aleksander Tkach, Vascular Neurologist, Medical Director for Stroke and EVT at Interior Health, and Marie McClelland, Clinical Research Coordinator and Stroke Nurse at Interior Health. And we will start with Marie, who has her screen up and she'll be ready to go when you are.
Thank you. So I'm going to start off by talking a little bit about what stroke is and sort of lay the groundwork for the rest of the presentation. Dr. Tkach is going to take over partway through. So a little bit about me. I've been a registered nurse for quite a few years. I'm also a stroke nurse and involved in quite a few different projects here in Interior Health and in KGH. I've been a clinical research coordinator here in Interior Health since 2017, but got a lot of experience when I became a clinical research coordinator with the stroke program in Calgary. I'm also a member of the Canadian Heart and Stroke Best Practices Writing Group for Hyperacute Stroke Care. We meet every 2 years to upgrade our standards to reflect best practice, and it's evidence-based on research that we look at from around the world. So I'm hoping to answer some of these questions for you. I'm going to call it Stroke 101. It's just basically, what is a stroke? What is a TIA? How do I recognize that? And what should I do if I do recognize that someone may be having a stroke? And what can I do to prevent a stroke? So to begin with, there's two types of stroke. The first kind of stroke is called an ischemic stroke, which means lack of blood flow to an area. And the second is a hemorrhagic stroke, when a blood vessel ruptures in the brain. So hemorrhagic stroke occurs in 15 to 20% of all strokes. And this, when the blood vessel ruptures, it causes a lot of damage to the surrounding tissues. And an ischemic stroke is when a blood vessel supplying the brain is occluded by a clot or atherosclerosis. This accounts for 70 to 80% of all strokes. Both of these types of strokes cause serious brain injury and brain death to the affected area. And a TIA, or transient ischemic attack, is when a blood vessel in the brain is occluded temporarily by either a blood clot or perhaps a piece of plaque. Symptoms can last for minutes to hours, but resolve completely according to the definition. This also brings an increased risk of stroke within 72 hours. And that's why it's so important to identify the cause so that we can hopefully prevent the risk of another stroke happening, because we have no way of predicting. You may have a transient ischemic stroke with minor symptoms that resolve, but we don't know if you're going to have another event, and if you do, if it's going to be a small one or a large devastating stroke. Blood clots can originate in the brain in a vessel that is narrowed because of atherosclerosis, and platelets start to stick to the walls of the narrowed portion and eventually occlude that artery. Another place that clots can form is in vessels leading to the brain, such as the carotid artery here. This is the internal carotid artery leading up to the brain. You can see where it bifurcates and goes up here. This is where a lot of plaque likes to form, and clots can form. A piece of clot can break off from a partial occlusion and go to the brain, or it can completely occlude the carotid artery. And clots can form in the heart. So if you have valvular disease, or if you have a condition called atrial fibrillation, or other conditions that will increase the possibility of you forming clots in the chambers of your heart, which then are sent to the brain when the heart contracts. So what should you do? You see somebody having a stroke, you think, maybe. So this is what we want people to think of: to act fast. The face. Does it look like one side of their face is drooping? Their arms, and I'm going to demonstrate here. Can they hold both arms up like this and hold them there for a few seconds? Speech. Is it slurred or jumbled, or can they speak at all? And time. It's time to call 911 right away. Time is brain. The sooner that patient gets care, the sooner we can do something to try and preserve their brain. So when a person's having a stroke, they can lose up to 2 million neurons a minute. They can lose 14 billion synapses. They can lose 12 kilometers of myelinated fiber. And the more brain you lose, the more serious your stroke is going to be. So currently we have a treatment for ischemic stroke. It's a clot dissolving medication called TPA, or alteplase, that must be given within 4.5 hours from onset of stroke symptoms. Not all patients are candidates, and the neurologist has to consider the risk versus the benefit to make sure that the patient is going to be getting the best possible treatment without endangering them. We also have another treatment here at KGH called Endovascular Therapy, or EVT, and I'm going to leave that to Dr. Tkach to talk a little bit about later on in this presentation. So what can I do to prevent a stroke? Number one, I think it's really important to follow the recommendations of your physician and to know your risk factors and take steps to reduce them. It's really important that people are champions of their own health. And so let's talk a little bit about those risk factors. So risk factors you can't control. You can't control your age. You can't control your gender or your ethnicity. You can't control your family history or the fact that you may have had a prior stroke or TIA. So age is a factor, definitely. I've taken care of children who have had strokes. It can happen at any age. But as you age, your risk for stroke does increase. Gender, certainly in our older populations, men appear to be more at risk, but ladies were catching up fast. Ethnicity, certain ethnic groups are more susceptible to stroke risk factors. Family history, if you've got a strong family history of stroke or heart disease or what we call cardiovascular disease, then you probably have an increased risk as well. And you can't change the fact that you may have had a prior stroke or TIA. So this is the big one. This is the elephant in the room, the risk factors you can control. So the previous one, this risk factors that you can't control, that only accounts for about 15 to 20% of your risk factors. Risk factors you can control, this is up to 80% of your risk factors. So stroke is a preventable disease. And the biggest one is high blood pressure. So if you can maintain your blood pressure within the recommended limits of about, I think currently it's 140 over 80, you can reduce your stroke risk by 40%. That's huge. You may have to go on medication if you cannot control your blood pressure through other means. Diet. Now, diet's really important too. So following a healthy diet, and certainly the Mediterranean diet is one of the best and is being followed by a great number of people around the world. And again, Dr. Tkach is going to speak to that a little bit in one of his slides. High cholesterol, this is another problem. So it's high, low density cholesterol. It's the culprit here because it causes our arteries to get blocked up with plaque or atherosclerosis. Smoking, it's just awful. I've heard it compared to when you smoke, all of the chemicals, all those horrible chemicals that are in smoke actually get absorbed into your bloodstream. And a doctor I used to work with said if you consider ground glass coursing through your arteries, just shredding the lining of your arteries, those chemicals do a lot of damage. If you can quit smoking, you again are reducing your stroke risk hugely, but you're also taking care of your lungs and the rest of your body too. Diabetes, and again, it's really, really important to maintain your blood sugar within a healthy range because high blood sugar damages your arteries and damages your organs. If you have heart disease, it's very important to manage your heart disease under the care of your physician, and particularly if you have atrial fibrillation. If you're in atrial fibrillation and you don't have appropriate care plan in place, your stroke risk can be as high as 20 to 30%. Being overweight. Being overweight is a really tough one because your body learns to make friends with that fat, and it's hard to lose that fat. But being overweight puts strain on your heart, on your muscles, on your bones, and it makes you a little bit less inactive. Physical inactivity is also a big contributor because the more you move, the healthier your muscles, your blood vessels, your heart, and your brain are. Excessive alcohol consumption, current recommendations are that you should not exceed more than 2 units. So a unit would be a 5-ounce glass of wine, perhaps, or a beer. Don't exceed that in a day because excessive alcohol is very toxic to your brain and to your heart. And you don't want to give them anything more to deal with, especially as we age. and stress. And I'm not talking about, one-time stress or a certain incident stress. I'm talking about prolonged stress over a period of time that elevates your cortisol levels, because then cortisol levels has a direct effect on your blood pressure, and again can predispose you to having high blood pressure, and that again increases your stroke risk. And sleep apnea. There is a link between sleep apnea and stroke risk. So again, get assessed. If you need to start adopting measures like a CPAP machine, please do so. So I'm going to hand over to Dr. Tkach and let him take over. And I'm going to, oh, that didn't work, so sorry.
Can you guys hear me?
Yes.
Okay,
Yes.
great.
Alex, do you have control? I'm just trying to hand over the controls to you.
There we go.
It's
I think I got it. Okay.
Okay, great.
So I'm Alex Tkach, I'm the Medical Director for Stroke Care and Interior Health. Thank you very much for allowing us to come talk, and tough talk to follow there. So I was tasked with sort of the research side of things. And when I talk about stroke research, I'm not talking about this. This might be what's in a lot of your minds, sort of the scientist in the labs that's not really seeing people. I'm really talking about research that looks like this. It really is at the bedside. It's how we take care of patients. It's how we take care of our loved ones. It's not necessarily a pill. It's really a process of making people's lives better. So we can go from something like this to something like this. This is a gentleman that I took care of a few years ago who, in his late 40s, while doing a multi-day bike race, had a stroke. And he couldn't move that right side. He couldn't talk. He was a lawyer. And this is him a few months later with his last visit before he goes back to work. So that's really what we're trying to talk about when we go to research, is really at that patient-centered thing. So what are we doing here? We've got a couple trials that I think you guys might be interested in hearing about, and I'll talk a little more broadly about the implications of these in our community. One is just, it's what we call a registry. So it's a thing where we put all of our data for our patients into one spot, but this is actually kind of a big deal because it's used throughout Canada. So we can compare our data to everywhere in Canada, and then we can go back and look at this data and see not only how are we doing, but when we make changes, how did that happen? How did that impact our system in a way that we can actually share throughout the nation? And then that allows us to share it even more globally. When you want to do something like this, you have to invest in a structure to make it happen. So who's putting in this data? Where is it coming from? How good is it? Making it reliable and continuous not only helps us with something like a registry, but that actually helps us provide good patient care. We need to know that stuff as well. So I kind of talked about this. It's pretty exciting. So one of the more exciting things we have here is called the Frontier trial. So the idea here is we give a drug before the patient even gets to the hospital to try and protect the brain from getting worse. As you heard from Marie, as the brain loses blood flow, it loses almost 2 million brain cells a minute. So what if you had a medication that slowed that process down, gave us more time to restore blood flow? And that's what we're trying to use this drug called Neurologist for. So far, it looks like it has almost no side effects. And so we're giving it in the ambulance before patients get here. And so far, the preliminary data is very promising. We're very excited about this medication. It has a very good chance of revolutionizing our care for stroke, not just here, but globally. But we'll figure all that out as the trial's completed. But one of the themes about doing research is echoed in this trial, which is to say, when you do a trial like this, you have to create a structure where paramedics feel comfortable giving a study drug. You can make sure you're giving it to the right patient, you're collecting that data, you're doing it safely. There's a lot of regulations to keep people safe in research studies throughout Canada that we have to go through that process. So you can imagine trying to get that set up in a way can be done before the hospital in a way that's safe and reliable and fast if people's brains are dying so quickly. And so we've been able to accomplish that with this trial And so even before we know the results of this, the structure that's in place to have that happen has already produced a very high increase in our quality of care in the region, because now our pre-hospital providers have so much more education and training and resources at their availability in a way that we didn't have before the trial. So we're pretty excited about this. We'll see where this goes in the future, but again, we've already seen really positive impact. Similarly, there's another trial here called the ACT trial. Maureen mentioned this medication called TPA that we use to break up clots, to restore blood flow to the brain. There's sort of a newer version of it called TNK. So it's probably a little bit safer, maybe a little bit effective, but that's why we're doing a trial on it here. Same idea though, when you look at giving this drug quickly and randomizing people between one or the other, when we think they're both quite safe and effective, but maybe one is slightly better than the other, that's kind of why we're doing the trial. But in order to do that quickly, again, you bring a quality of care to the whole program that really improves patient care regardless of the result of the trial. Now, these trials are part of national level trials, and we are participating at a level that, if depending on these outcomes, stands to change stroke care globally. That alone is pretty exciting. But when we do these trials here, we are really setting a new precedent in terms of acute stroke research. Traditionally, these trials have only been done in urban and large academic centers. So it turns out Canada doesn't always live in a large urban academic center, and a lot of the world doesn't. And so by bringing these studies to interior health, we're able to bring sort of a higher, sort of more than standard of care to a population that otherwise wouldn't have it. And we're hoping to be able to extend trials like this to even outside of Kelowna in the near future, again, to try and improve care at the time the trial starts, but also to improve access to research that is just otherwise not available. And so we really have put in a lot of time and effort in this, and this is sort of our next frontier in here to produce this thing. So, that's a bit of a view of our research here, what we hope to accomplish. As Marie mentioned, we now have an endovascular center here where we go into people's brains and take out clots. A lot of pretty exciting things technologically happening. But I want to kind of bring this full circle back to sort of the people that are watching this video. You might not really care about research or quality improvement projects other than saying that sounds good. But when we look at research across the spectrum, it really does come back to you. Oh, I think one of the fundamental ways this is represented is with diet. So diet is the foundation of good health. What I mean by that is I can give you pills, I can pile pills on top of you, but if you don't have that core foundation, that structure of good diet, I can't help you. You can't out-exercise a bad diet. You can't out-medicate a bad diet. And so if you're not willing or able to change that, then it's really hard to say aspirin's going to help you or a atorvastatin is going to help you. And so it's really, really important to keep this in mind. And we try and keep that in mind, that sort of patient-centered focus as we do research. In terms of diet, there is a lot of studies, actually, but only a few that are really high quality. And probably the best one that I like to talk about is this one where this Preventable study completed several years ago, but it was a multinational trial out of Europe where they took people who were over the age of 50. They had some vascular risk factor, meaning that they were diabetic or they smoked, or maybe their dad had a heart attack when he was 48, something like that. But they had not had a stroke or heart attack yet. And they randomized them to just keep on doing what they normally do for their diet or to take the Mediterranean diet. And then they just watched them. Now, diet studies are really difficult to do. How do you really know what people are eating and such? So in this trial, they actually at first talked to them every day for quite a bit of time, but then they talked to them every week for years on end to do diet surveys, diaries, and really kind of make sure people are staying on track. Many, many people. I mean, 7,000 people where you're talking to them on a regular basis about their diet. It's a hard study to do. This was throughout Spain, France, the UK, and Italy. So their standard daily diets were actually quite variable between these countries. At 3 years, they had a 30% reduction in the Mediterranean side of it compared to the people who were just going about their normal daily diets. And that was regardless of which country they were looking at. So it's really about the only diet trial to look at this as we would a pharmaceutical trial, sort of randomize them, control them, monitor them, and get good data on the follow-up. So this is not to say that this is the only diet intervention that you can make to make a big difference, but it has the most data behind it. It's easy to find recipes, it's easy to find guidance. There's a bit of variation in what we mean when we say Mediterranean, but in general, it's all pretty similar and good outcomes from it. So I think I'd like to kind of wrap up a little bit here. We don't have a whole lot of time left, saying, most strokes are preventable. So when you look at all these things combined, so 80% of strokes, just the first strokes, are preventable, and that is blood pressure control. If you have atrial fibrillation, taking your anticoagulation, diet, as we mentioned, exercise, all these sorts of things. If you have a stroke or a small one that gets better, transient ischemic attack, TIA, and we change all these things, we take care of your diabetes, stop smoking, you eat right, exercise, all these sorts of things, we reduce the chance of recurrent stroke by about 90%. But it's not just a pill, it's not just one thing, you have to do all of it in order to get that benefit. So I can go on and on about diet, and it can become quite complex. But I think there's a beautiful summary. McClelland is kind of credited with this quote, which the summary for diet is you should eat food, meaning not artificial stuff, processed food, all that sort of stuff, but actual food. You should try and make it mostly plants and not too much. If you stick to that, you will reap the vast majority of the benefit from a diet change. Stay active. This is important not only for stroke, and diet's not only important for stroke. Both of these also do things like prevent cancer, prevent dementia, help you with osteoporosis, osteoarthritis. So all these things that we take into account as we look towards our later years in life are improved with these simple remedies. And in reality, do you really need a stroke neurologist to tell you that? You already know this. So that's why I like this idea that I can use research, but it basically already tells you what you already know. Eat right, exercise, and you're going to do a lot better. And I don't have a pill that replaces that. In interior health, we've worked a lot to provide a network of care across the continuum, preventing stroke, treating strokes, rehabilitating strokes. And this is not only here in Kelowna, but we try and make this accessible to everybody, regardless of the location and their backgrounds. Research is exciting, and we're really seeing benefit in our communities real time. And we really feel like we're on the cusp of being not only leaders in the area for research, but through Canada and even beyond. So the brain is what makes you, you. When you lose that, it is a life-changing experience. Some people really feel like they've lost their loved ones. They're not the same person anymore. This is preventable and treatable. And again, it's pretty easy to employ things like diet, taking an aspirin perhaps, or just watching your blood pressure. So it sounds complex, it sounds scary, but it turns out you have the power to change this and take control of this in a way that nobody else does. And so I hope you appreciate that, because it really does change your life, okay? If you do seem like, you might have symptoms of stroke, which generally are acute onset of trouble talking, walking, face droop, weakness, can't see, that sort of stuff, you need to call 911. Every second that goes by is a second that we could have used to save brain and prevent long-term disability and get you back to being you, get you home, give you the ability to hug your loved ones again, take care of yourself, see your grandchildren, etc. So with that, I'd like to leave plenty of time for questions.
Great, thank you very much. We do have a lot of questions already. So maybe Michelle, you could start off with the first question. We're going to read them out so that if people aren't able to see the questions in the chat, they can still hear the question being asked. So Michelle, I'll let you start off.
Sounds good. So the first question is regarding the Frontier. If the drug is on trial and administered in the ambulance, does that mean only a certain number get the actual drug?
Yeah, that's exactly right. So it's a randomization. So it's 50-50% chance you get placebo or drug. I don't know which one you get. And we'll figure that out in the end if there's a difference in outcomes.
So the next question is a little bit different, but kind of interesting as well.
John, before we go on.
Oh, sorry. Go ahead, Marie.
Sorry, I just wanted to expand on that. What Alex didn't say is that before the paramedics can administer this drug, they have to call the emergency physician on call system and speak to an emergency physician. And they go through a very, not long, but they go through a list of very specific questions to make sure that the person is having a stroke and they do meet criteria for the study, so that we're very careful not to give this drug to people who it isn't meant for.
And same thing with sort of, same thing with the standard sort of ethical good practice for research guidelines as well. They're all adhered to in any of these trials.
Right. And in relation to that, because it's happening in an ambulance, so when do people actually consent to be part of this research then? Because they might not be able to right at that moment in the ambulance. How does that work?
Yeah, so that's a really good point, and it's a difficult thing. It's a difficult thing to consent people for acute stroke trials because, as we say, every second counts. So delaying, care because you want to consent for a trial, that's problematic, right? That seems unethical. And so with this particular trial, this drug seems to have almost no side effects and no major risks at all, and that's been validated multiple times. And because it is such a safe medication with potential benefit, it has what we call deferred consent, which means that you could opt out of doing it. But if you can't speak for yourself or don't have somebody speak on your behalf, we will give it to you. We will randomize you to either placebo or the medication. And again, that's kind of gone through a lot of ethical screens and such, but that's about the only way to really do trials like this. And we will only do that if we are absolutely sure that the drug is safe.
Right. And so if you end up with being on the placebo end of this particular trial, will you still get that usual drug that's
absolutely, yeah. So it doesn't preclude any other standard of care. And that's the same for all of this research. So when you look at the care that patients get who are in a clinical trial, we see more care essentially. You have more contact with Marie, for instance, if you're in one of the trials that she's running, she's going to check in with you. So we do see more contact with providers, with people who are in research. That alone will likely translate to improved care. And it does not preclude, doesn't take away the ability to do any other sort of treatments or options or rehab, anything like that. So it doesn't affect that at all. It is this idea that you get more care in a fashion is why we're so passionate about bringing more research to the area, so we can get everybody enrolled into a trial who comes in, regardless of where they live.
Great, thank you.
I'd like to add to that as well, regarding the consent. The paramedics are instructed to ask at the scene if there's any objection. They give a very, very, very brief explanation of what they're intending to do with the study. So with the deferral of consent, after the person arrives in the hospital, then it's up to the clinical research coordinator to contact the patient and their family if the patient can't speak for themselves, and go into the study's involvement in detail and get what we call informed consent. And people can opt out of it at that time. Obviously, we can't take back the drug that's been given or the placebo that's been given, but if they don't want to follow up or have any further assessments that are related to the study done, then we absolutely respect that. The ACT study also has a deferral of consent. And with Optimize, it's not necessary to get consent because all we're doing is collecting data, which we would have done anyway.
Right. Great, that's very helpful. This next question is actually interesting. The Nordic Ski Club recently raised $50,000, wow, for the stroke services at KGH. How might this money be used? And I was just mentioning to Marie, this is such good timing for this presentation, because in the Courier today, there was like a 4-page spread about stroke and some of the things that you're needing money for.
Yeah, so exactly. We're launching our stroke campaign right now. And so this money goes to that campaign, and that campaign has a lot of different aspects of it. It is largely related to the stroke network. So some of that is infrastructure costs. That's a big bulk of it. We want to update some of our fancier equipment here, particularly the ones where we go in and take out directly the clot from the brain, called endovascular therapy. That's a really important service to have here at Interior Health. Before we were able to do that here in Kelowna, people would have to go to Vancouver, but the transfer times are so long that very few people were able to receive benefit from that. These strokes are the largest. These are the worst outcomes. People who don't have the vessel reopened have a very high chance, about 85–90% chance of being bedridden or dying. When we can get these blood vessels open up quickly, then that number almost reverses. About 15–20% then have a long-term bad outcome. The rest actually do quite well. So it's quite a life-saving and sustaining sort of technology, but it does require a lot of infrastructure investment to make it happen. So that's one big aspect with it. But you know, this also goes to sustaining sort of producing more research here. It goes to quality of projects. It gets to preventative projects. So it's quite spread out throughout here. It's things, yeah, I could go on and on about it apparently, but that's kind of the short answer.
That's great. Thank you. Michelle, I'm going to turn it back to you for the next one.
The next question is, I'm curious to know if diet data and research for stroke prevention is being transferred to long-term care, residential care homes for menu planning.
Oh boy, what a wonderful question. You know, for those of you that are more interested in this diet stuff, there are a couple local physicians. Jade DeTero is probably the one in our area that does a lot of this sort of stuff. She's a fellow. There's a fellowship you can do in lifestyle medicine, actually. So it's not just diet, it's, you know, a lot of other things as well. The non-pill stuff that actually is so important. But there is a lag. There's definitely a lag in the recognition of this diet and how that's actually getting incorporated, not just within, say, long-term care or residential homes, but also even within the hospital. And so I've had conversations about this. You know, I say, boy, I'd like to have this Mediterranean diet, but I actually can't order that for you as a patient here. And that's been that way every hospital I've been at. That's nothing new, and it's something that does need to change. But then we're starting to talk about things that are a bit beyond what I have ability to control. You're talking about like industrial food chain sort of changes, which are a bit harder to change and really do need to come from the ground up. People need to recognize the benefit of eating differently and demand differently, I think, to make these changes. So I think that these things should be offered anywhere people live, especially if they're in areas where food is being prepared for them. But and I can help, but really people have to be part of that advocacy to raise awareness and make these changes at that level.
That's great. Thank you. It's interesting because we're having a lot of conversations about plant-based foods and climate change and sustainability at UBC, and we have a new initiative called Nourish You to focus on some of these topics. So this is great.
You know, the other thing too is that where we live, there is just no excuse. We live in some of the best food producing regions in the world. You've got, you know, you've got these pastoral raised food just north of here, all over the Okanagan. So when anybody tells me, oh, that's hard to come by, you are not getting any sympathy from me around here. You have one of the best opportunities in the world right out your door.
That's right. I agree. I totally agree. So this next question is kind of interesting, and it's for you. Great presentation. At what point in the ACT trial do you as a research team feel ethically compelled to deliver TNK to patients when you increasingly include it's beneficial to the patient? And how do you balance that with
this is Jason. So Jason is Jason. That's a bit of a plant, I would say. So Jason has a little bit insider track here. He's the rural research coordinator for Interior Health down in Penticton. So he has a little bit of insider knowledge here. So yeah, so TNK is a medication that's been around for a while. Cardiology has been using it for heart attacks for quite some time. They also started out with TPA, but they switched over to TNK because it seems to be a little bit better at attacking just the clot. The idea here is that you give a medication into the vein, It goes throughout the body. And the idea is that it breaks up clots to restore blood flow to the organ that needs it, like your brain, but it goes everywhere. So if you have other clots that are dissolved that you might need to prevent bleeding, then you're going to have bleeding problems. That's the risk with these medications. TNK is a little bit more specific to an active clot, meaning that, if you had a fall and a bad injury to, say, your leg, like a couple weeks ago, that the TNK theoretically has a little bit less bleeding risk compared to the TPA. So we're trying to see if that's true in the stroke world. It's been semi-demonstrated in the cardiac realm, but the cardiac dose is different and the indications are a bit different. So you can't just assume it's the same. You really do need to demonstrate the benefit versus risk in a new trial. TNK has some distinct advantages. It is much easier to use. It's about the same cost. There's no real cost change there. It is more available because it gets used for cardiac stuff as well. Everybody has it in almost every facility in interior health, whereas TPA is only in the places where there's CAT scans. So it has some unique advantages right off the bat that way, but we still have to do a trial to really know if it really is safe, if it really is effective, and that's where we're at. I think about this on a regular basis, and actually I was just talking to the doctor who created the ACT trial yesterday about this exact subject, that as we go, is there data that's going to say at some point we can't do the trial anymore because it's not ethically to randomize because we might have safety or superiority things. And so with any trial, including this one, there's what we call interim monitoring. So you get to a certain point where you've enrolled enough people and you stop and you say, is it still safe? Can we still proceed along? We're about to get to that first spot with the ACT trial, actually. It's coming up very soon. So we will look at that. If we don't have any safety concerns or anything like that, we'll keep going to really try to get at this question once and for all. But if we all are expecting that at the end of this trial, we will not conduct another similar trial. We will have an answer, and then it would be unethical to continue.
And if the benefits were really outweighing any risks, the benefits were outstanding, you might also stop the trial early. Is that right?
Exactly. So if the interim analysis gave us something unexpected, that it was a superior medication, then yeah, we'd have to stop the trial. The interim analyses in general are designed to make sure it's safe, that we're not causing excess harm to people. Yeah. And so that would be another reason to stop it. But there definitely have been trials that have stopped early because of superiority. And the endovascular trials are a perfect example of that. So a few years ago, there were multiple trials going on throughout the world where we were saying, well, is it really the best thing to go up there and take out that clot, or do we cause harm? What is really the best thing? And the first trial to demonstrate that, it's called Mr. Clean, it was out of Holland, out of the Netherlands, said absolutely, it's a great trial. And it was so superior that all the other trials had to be put on hold, look at their data, and essentially stop because it could no longer ethically randomize people. So this definitely happens. We monitor these things when we're doing any trials. It's part of what we call good practice guidelines for research. And those guidelines that we follow here in Canada are very similar. And in Europe, it's called something slightly different. The same thing in the US. Every country has a slightly different name for it, but it all follows the same principles for ethical research.
Mm-hmm. That's great. Thank you. Michelle, over to you.
I understand the diet thing and exercise thing, but wondering if taking a statin helps. I know you say pills help, but do the pills actually really help?
I can answer that from a personal point of view. So quite a few years, about 15 years ago, I was diagnosed with high cholesterol and decided that I wasn't going to take a statin. I was going to tackle it from diet and exercise point of view and put myself on a very strict regime. 2 years later, nothing. I still had high cholesterol. So I went on a low dose statin. I still exercise and I still follow a very healthy diet, and I take a low dose statin to maintain healthy cholesterol levels, because I do have a strong family history of cardiovascular disease, and I'm just not willing to take that risk. And so, yes, sometimes a statin is necessary. Sometimes diet and exercise is not sufficient to reduce your cholesterol levels to the recommended level point. And Alex, absolutely jump in if you've got more to say.
Oh boy, this is a topic I can spend hours on. Cholesterol is, so when you look at your cholesterol panel, it's really giving you sort of just part of the story. Yes, if you have elevated cholesterol, you will be at higher risk for atherosclerotic disease, strokes, heart attacks, dementia. and things like that. Statins definitely reduce those chances, even regardless of what your cholesterol number changes. Statins have a lot of anti-inflammatory effects as well. It's a pill. It has risk and benefit. So when you look at patients who have high cholesterol and don't change their diet, take a statin, they get benefit. They do. It's not an incredible benefit. The number needed to treat in that regard is about 100, meaning 100 people have to take that pill for one of them to get benefit. If you look at people who change their diet, well, I just showed you the Mediterranean trial, it's actually a 30% reduction in stroke and heart attack. So the diet definitely has much more influence than the pill. But it doesn't mean that you should avoid one or the other. I mean, ideally, you end up doing both. And so there are a lot of trials looking at that exact question, that if you look at people who take a statin or not and just follow them long term, you know what happens. And it's not just stroke prevention, it also is heart attack. Interestingly, it seems to have even more impact on the younger population, even if we think their stroke isn't related to cholesterol. So there's just a lot more things that statins do than just cholesterol. And I think that's the takeaway point with that, is that, you know, if you've had any sort of cardiac or stroke problems, if you're at risk for these things, a statin is probably a good idea for you if you have elevated cholesterol, but really you got to do the diet as well. The thing to think about when you think about diet and cholesterol, it's similar to how you think about diet and sugar, is that I can measure a level where it kind of reflects your average over time, but the damage happens when you get a big bolus of these chemicals. And if you get a large amount of cholesterol into your system at once, like eating an egg, then your body can only handle so much of it. And that excess actually damages cells at that point in time. It's the same with sugar. Your body can handle a certain amount of sugar, but as soon as you get past that, it causes real-time damage right there. And because it's so transient, I don't really have a lab way of saying where that's at. But I can tell you that if you're a diabetic and you start taking insulin and your numbers look great, that's wonderful, but you didn't do anything for diet and exercise, you don't really have much benefit from there. You have a bit, it's good. You'll go blind a few years later than if you didn't be on the insulin, but you're still going to end up probably with neuropathy and retinopathy and all these other opathies that are bad. But conversely, if early on in your course you make these changes to control your blood sugar, or same with cholesterol, like Maria is talking about, you avoid all those things. They're preventable.
Great, good advice. We have a question from my colleague Dee Taylor. Thanks for the wonderful presentation. How can people get involved in stroke research? And I guess I would just add to that, not only people in Kelowna, but throughout Interior Health. So if I was in Trail or Osoyoos, are there opportunities?
I should let Jason or Dia answer their own questions. So Dee is the executive director for research, so she also has a little bit of insight into this question. So I would also say it's not just stroke research, I would just say research. Interior Health has a large, robust research group that's actually unique. Most research is done typically just through an academic institution. Interior Health has gone a little bit beyond that. And we work with UBC as well. It's not to say one to exclude the other or anything like that. We're actually working very hard right now to figure out how we combine these two resources more closely. There's a lot of research going on throughout the region, some of it via telehealth as well. And we really do want to expand these programs to places like Trail. And we're working very hard on that. So there are already going to be some amount of research available to you, regardless of a location. Some of the stroke stuff, not so much yet. We're working on bringing that in there. As you can imagine, there's some infrastructure that needs to happen to do these things well and consistently. So I don't have an easy answer for a place like Trail right now, but this is to say that people should be asking themselves, you know, what research do I have access? You can look things up on clinicaltrials.gov if you have a specific disease or trial that you have in mind, and just see. And there's a list there of contacts you can just call. You don't have to be a physician or a researcher to reach out to these places to see if you would fit for enrollment there. And if you did and it's not available to you, then why not? You can ask your physician, you can ask us, you can ask Dee Taylor, you can ask Marie of, you know, why wouldn't we do this in Trail? And we would love that sort of advocacy at the local level to be able to, again, not only bring the research, but all the other quality of care that comes with that research, that area.
Great, and I see Tkach has added another website for people to look for research studies. It's called reachbc.ca, and that will include studies right here in British Columbia on a wide range of topics. And also we have some researchers here at UBC Okanagan who are doing research to support people who've had a stroke after their stroke so they don't end up with another one. So around prevention and for further complications after a stroke. So
yeah, Joan, you might not want to toot your own horn here, so I'll just do it for you. I don't think people realize the massive amount of quality research done at UBC Okanagan, especially in the chronic disease side of things. This is a large part of UBC as a whole, and there is an amazing amount of research being done over there that we are always constantly trying to figure out how to integrate into the community as a whole. So I feel people should, I feel like that doesn't get talked about enough, and we really should have more public awareness of the amazing things going on out there.
Thank you. Yes, I agree. And if people are interested in some of the research, they can go on to the Institute for Healthy Living and Chronic Disease Prevention website and check out what's going on. It looks like we've almost run out of questions, but I have a question. I'm wondering, just because we're still in this pandemic and it is always on the news, I can't help but think, based on your observations over the last year, how has the pandemic influenced people's response to stroke symptoms, our healthcare response to managing stroke? Do you have any observations about that?
Yeah, our observations here kind of echo the observations that have been seen globally, at least the global populations that I have access to data and the researchers, and we talk. You know, we're starting early on in the pandemic. We actually started doing international sort of conferences about what we're going to do for stroke and how to adjust. And initially that was just kind of talking to Milan and Manhattan, places that were really getting hit hard. But now it's really gone much broader than just, you know, the acute response phase. And there's a couple of things that really are interesting that we don't necessarily have all the answers for just yet. One is that the stroke rate actually decreased quite rapidly right off the bat. And we think, our guess is that's because people couldn't access sort of these lifestyle things that were harder to do with COVID. You couldn't go out, you couldn't go get fast food, you couldn't do a lot of these things. You had to maybe go for a walk. You weren't sitting, you know, people could only sit at home for so long. So we think some of that might have been that. We definitely saw, unfortunately, a much larger increase in delay to treatment. And so probably going to see a spike in worse outcomes with that. So that's definitely been an issue for sure. And how to sort this out and, you know, how to react to it is still a bit unclear because we just don't have all that data yet. It's just too soon to really be able to analyze it. We have definitely, and Interior Health did amazing work early on to provide telehealth, you know, audiovisual aids to do stroke care and in people's homes, et cetera, right off the bat. I mean, I moved here to really work on this sort of infrastructure ideas to produce a lot of telehealth care. Is one of the reasons I came here. Interior Health has been doing this for a long time. And we had this goal of getting it into people's homes over the next few years. And that 3-year plan or so happened in about 3 weeks because people worked overtime to really make it happen because it was the right thing to do at that time. And so we are seeing some benefits actually from this pandemic, that we have accelerated the infrastructure to provide that care in the non-office setting.
Mm-hmm. Marie, do you have any comments related to this from your observations of working with patients and families?
No, I was very impressed with how quickly Interior Health and this institution here at KGH got things set up so that we could still, after a few weeks period when we were setting up all of the necessary precautions for protecting patients and staff, we were able to have access and we were able to start up our research projects again. There was a very brief delay of about 6 to 8 weeks. And we were actually leading Canada in being able to get our research back up and running. And for a lot of our patients, it was a safety thing. They might have been on an experimental treatment, and they needed the follow-up, and they needed the advice that they got from the caregivers that were helping them within the confines of the study.
Mm-hmm. And how have patients responded and families responded to the telehealth focus or shift, do you think?
Well, I mean, you know, it's medicine's behind in this field, right? I mean, you can get on your phone and figure out what taxi or Uber or whatever is next to you and just hit go and you're on your way. You do your banking almost all virtually. You know, the idea that you have to go to one place to have just a conversation is long overdue for a change. So we really have seen a very universal embracement of it. However, I think the story of this technology in this context, we have to be very cautious of the people who just do not have access, because these are people who already have trouble with good and equitable access to care. And this can disenfranchise them even further. So that is something we have to be very, very careful with. That's also something we spend a lot of time thinking about in research, that if you're going to do a research study in Kelowna, and you're not doing it other places, there are other people, other populations that aren't, you know, that don't have equitable access to care, and you're almost making that worse. Mm-hmm. So we have to be very cautious that this isn't going to solve everything sort of thing, because not everybody has a computer, not everybody has a smartphone, not everybody has internet, at least not reliably. And even though that seems maybe a bit, it doesn't seem like something you often have to deal with, especially people who are on a Zoom conference like this, it actually makes up a sizable percentage of our population.
That's really great. I see we're almost out of time, so I'm going to invite you both to make some closing remarks or some last bits of advice that you have for people, and maybe we could start with you, Marie.
I think it goes back to people being aware and being champions of their own health, and moving to the mindset that if you don't like what's going on in your body, then you need to work with your doctor, and you need to educate yourself on how to live the healthiest life that you can. And it sounds simple, but I know it's not. One of the things that I advise my patients when I'm telling them that it's time to make a change, I tell them to change one thing and one thing only. Mm-hmm. Stick to that for 2 weeks, whether it's a diet or quitting smoking or whatever, walking every day. Do that for 2 weeks. And if you think you can maintain it at 2 weeks, then implement another change and do that for 2 weeks. You do it slowly, you incorporate it into your lifestyle, and then it's not so hard.
That's great, great. Dr. Tkach, do you have any closing comments?
I completely agree with what Marie just said. I mean, you are the master of your own fate in this regard. Your health is up to you. Nobody can do that for you. And it doesn't have to be a sprint. You don't have to do everything all today. The way I look at it when I talk to patients, and I say, why would you not? You know, when you have somebody who's smoking, I don't assume that they're ignorant or addicted or anything like that. I just simply ask, why are you smoking? You know it's not good. You're not dumb. So why are you doing it? And if you can't really kind of wrap your head around that, then that's really the starting point of the conversation. It's the same with diet. It's the same with exercise. Again, do you need a stroke neurologist to tell you these are good things? Absolutely not. Then why are you not doing it? You know, what is it about these things? Convenience, comfort food, et cetera, right? There's all these reasons, but they're personal. And so you need to figure out, why would you make this change? What do you want to do? And start incorporating those pieces as you can and as you go to fit into what works for you. It's not a one size fits all.
Great, great. I see there's a couple of closing comments from our participants as well. Michelle, do you want to read them out?
There's one question and a couple comments, but so I can put them in there. Are you aware of any grants or funding for communities to develop programs for stroke prevention? For example, safe walking trials for elderly people. I'm trying to think of how data on the stroke prevention can result in tangible community opportunities.
So Jason Curran on this could help out with a lot of sort of some of that detail as well. But I would say that's exactly the kind of research going on at UBC. So that'd be my first comment to something like that, would just be, see, there might actually be a trial exactly with what you're looking for your community that's going on right now. There's actually a very good chance there is.
Yes,
I
I
can look
agree.
for
There
a
probably
contact
is.
there. Yeah.
And Michelle,
And
why don't you be the last one?
I have from Carol, I have a real appreciation for this presentation, especially Dr. Alex frankness and reality-based comments resonate with what I need to initiate with my dad, a stroke survivor. Even comments about diabetes with regards to medication combined with healthy diet and exercise and what happens to blood vessels were very informative. I feel informed, empowered, encouraged, and hopeful. Thank you very much.
That seems like a lovely way to end. So thank you, everyone, for joining us today. And a special thanks to our speakers, Marie and Dr. Tkach, and Michelle for helping us organize this today on behalf of Interior Health. And I hope people have a chance to join one of our other sessions in the future this week and in over the coming weeks in the Embrace Aging program. So hope to see you again soon. And thanks again, everybody, for joining us. Bye-bye.
Thank you.
Thank you for having us.
Thank you.